So as you are well aware, there are two different kind of theories of cancer. One is kind of the somatic theory of cancer, more DNA based, so that when our DNA gets damaged, that creates cancer. But really what's become far more evident is that really it's more mitochondrial based. It's more the metabolic theory of cancer. And so when these mitochondria within our cell so the mitochondria, which are these little organelles in the cells, become damaged from lots of different insults, that they stop functioning. And when they are getting distressed, they send off these signals that actually then change the DNA. So more what's called epigenetics, so turning on or turning off certain genes. This is a representation of a cell with just a single mitochondria, which obviously is not correct, but what it's really trying to show is that the bulk of our energy is made within the mitochondria. That is where all the green up arrows are. I don't know if it'll show here. I thought I had them. There we go. So you can see how most of those are in that green mitochondria. So as the mitochondria get damaged, we start to rely more on glycolysis. And you know, the Warburg Effect is what is known as the utilization, or I would say the conversion of glucose to lactic acid, or to lactate. So when the mitochondria are not working well, the pyruvate doesn't get transported into the mitochondria for fuel. It gets converted to lactate. And Dr. Otto Warburg realized that in cancer cells, that these cancer cells all created more lactic acid used, and despite not being in an anaerobic state, but being in an aerobic state, meaning that oxygen is present. And he found that this was due to these damaged mitochondria, although he didn't call them mitochondria at the time, they were called granules. So how do we know that mitochondria are really at the heart of this disease? Well, Dr. Seifried and colleagues did some nuclear transfer tests where they actually took cancerous nuclei or nucleus, so where the DNA is kept, and put into a normal cell. And in theory, if the DNA in the nucleus is the driving factor, those should have become cancer cells, but they in fact became normal cells. Whereas if you put a normal nucleus into a cell that had damaged mitochondria and cancerous cytoplasm, those cells actually did become cancer cells. And Dr. Elliott did some nuclear transfer studies. That's where, so a couple of things. One, he noted that low-grade breast cancer had more normal and more numerous appearing mitochondria, intermediate grade, more sparse and vacuolated, and then highly aggressive breast cancer really had no mitochondria. And what he found was that when he transferred normal or healthy mitochondria into cancer cells, it caused them to grow more slowly. And when he transferred healthy mitochondria into cancer cells, it caused them to become more sensitive to chemotherapy. So what has been shown is that when we use fasting or fasting mimicking diets, we can actually activate an adaptive cellular stress response signaling pathways that enhance mitochondrial health. So we're actually trying to improve or heal the mitochondria, which also helps repair DNA and also leads to autophagy, which is death of damaged cells. So we're getting rid of some of these cells that are not suitable to health. This is a graphic looking at the differential responses with fasting or fasting mimicking diets. And in the first section, you see these are normal cells using either a regular diet or fasting mimicking diets with a chemotherapy. And you can see in the regular diet, many cells are killed with the chemotherapy cancer. So these are in normal cells with the chemotherapy for the cancer. which leads to side effects. But if those normal cells are in a fasting mimicking state, then they actually survive far better. So there's more cellular protection, there's a decrease in side effects. But what I want to spend a little more time on tonight, which I know I've done in the past, is really looking at the tumor cell. So what happens when we combine fasting mimicking diets or fasting with cytotoxic cancer treatments? What we see is that the tumor response, so these are now tumor cells, that there are a few that will survive when we use cytotoxic chemotherapy, and that's why we typically do multiple cycles. But when we're in a fasting mimicking state, we tend to increase the efficacy of the drugs. And we see that with many different types. So we'll look at a few of those. This was a study that looked at fasting mimicking diets, and this was just cyclical, so not constant. And this was done with breast cancer, hormone receptor positive breast cancer, and different types of hormonal therapy. And you can see the combination of the fasting mimicking diet with the tamoxifen or with the fulvestrant gave far superior reduction in tumor growth compared to either treatment by itself or the diet by itself as well. And in this study looking at immunotherapy, so an anti-PD-1 treatment with I'm trying to remember what type of fasting mimicking. This was just cyclical time restriction, but some type of, I think it was considered a short-term fast. And what they found again was that the combination of the short-term fasting with the anti-PD-1 was far superior than any of the others by themselves, both in overall survival and in tumor volume. And in this with PI3K inhibitors, they were looking, because PI3K inhibitors can increase that glucose and insulin response in a feedback loop, they looked at different medications that are typically used for diabetes, like metformin, like an SGL2 inhibitor, and then they combined it with the drug being the BYL719. That was the PI3K inhibitor. But you can see that although there was some effect of some of those medications or the ketogenic diet, which really actually appeared kind of better than the medications, but the combination of a ketogenic diet with that PI3K inhibitor was far, far, far superior to any of the others when we look at overall survival. This was looking at a ketogenic diet and just standard chemotherapy for pancreatic cancer. And again, you can see that we get better overall survival when we combine chemotherapy with a ketogenic diet. And this is looking at radiation. So combining radiation and a ketogenic diet was better than radiation with a standard diet. This was done in mice with GBM tumors or glioblastoma tumors, and where the blue arrow is where they converted the mice back to their standard diet and still did not see recurrence. Using cyclical fasting mimicking diets and looking at the effect or the complete response, complete or partial response versus progressive disease or no response. And we anticipate in breast cancer that when we give neoadjuvant chemotherapy, that most patients will have at least a partial response. And what they found is that if they just looked at all participants who were randomized to the cyclical fasting mimicking diet, almost 90% of them had a complete or partial response, whereas the regular diet patients, it was about 72%. But if you actually divided them out, not to what they were randomized to, but what they actually did, you can see that those that were compliant with the cyclical fasting mimicking diet, it was 95%. There was actually only one patient who did not have a complete or partial response. Those who did some of the fasting mimicking diet but did not do it as instructed for the entire course, still had very good at about 85. And then those who were compliant with the regular diet, because there were actually a few that kind of did fasting mimicking, but they, well, it was about 72%. When we look at patients with stage 4 colon cancer that were put on ketogenic diets versus regular diet, this included MCT oil as part of their fat. And you can see that there's a significantly increased rate of any response, so that would be partial or complete response. And if we only look at complete response, it was 50% in the ketogenic arm, whereas 0% in the control diet. And this was a recent publication. It was a case study. So a case study just means that a patient did something and then the doctors wrote about it as to what he did and looked at outcomes. But this was a gentleman who was diagnosed with lung cancer metastatic to brain back in 2007. He actually presented with neurologic symptoms, had brain imaging that showed multiple brain metastases. That's in the first panel of images. I don't know if you can see them, but there's little yellow arrows kind of pointing to where the tumors are. And he underwent whole brain radiation, so 2 weeks of whole brain radiation. He was found to have relatively limited disease in the chest. It was just a tumor in the right upper lobe, I believe, without significant adenopathy or lymph node involvement or other things. But he did get chemotherapy, I believe 6 cycles of chemotherapy, which would be standard, had a great response, and opted at that point, and I don't recall if it was actually when he started his ketogenic diet, if he started it with his chemotherapy or not, but he definitely did not start it with his radiation. I believe he did start it with his chemo, if I recall correctly. And he then started a ketogenic diet. He did a 1-to-1, which we'll talk briefly about again. So 1-to-1 means 1 gram of fat to every gram of protein plus carbohydrate. And then he slowly transitioned, and I don't know how long, but went up to what's called a 3-to-1. So 3 grams of fat to every gram of protein and carbohydrate. So kind of slowly increasing fat while decreasing protein and carbohydrate. And they continued to follow his brain. So the second panel of the brain images was from July of 2008. So that was after he completed all of his brain radiation and chemotherapy. And then another scan in October of 2009. So just about a year later. And you can see how much smaller, denser, kind of calcified those tumors are looking. And then they just re-scanned him in January of 2018. And now these are slightly different images, but again, really very minimal, if any, residual disease. And so he's doing very well. So we often think of lung cancer metastatic to brain as a very high risk disease, and he appears to be doing extremely well. Could he be doing extremely well eating a regular diet? Very possibly. This is not a randomized trial, but it is very interesting nonetheless. So just to review kind of the different levels of ketogenic diets, I always start folks at about a 1-to-1. So that's about 70% fat and 30% carbohydrates. Remember, the ratios, the 1-to-1 is in grams, whereas the graph, the percentages are in total calories, right? So fat has more calories per gram than protein or carbohydrates. So that's why, even though they're 1-to-1 by grams, you can see how they're very different by percent. And you can see that if you went up to a 3-to-1, you'd be 87% fat and 13% protein plus carbohydrate. I don't know if I've shared this ratio or this equation with you, but it's another one that was discussed kind of because protein and carbs aren't actually the same, right? We've looked at glucose and insulin curves on protein versus carbohydrate. And we know that, typically carbohydrates have the sharpest peak from a glucose perspective. So what this ratio looks at is it tries to account for the ketogenic potentials. So that would be the top, the numerator, as well as the varied insulin response. Those would be the denominator of our three major macronutrients, right? Our fat, protein, and carbohydrates. So you can see that fat predominantly or dominates that ketogenic potential, which is why those percentages are always high in fat. Protein, on the other hand, is kind of 50-50. And the reason for that is that some protein can be, if you overeat protein, you can create a glycemic response, or really it's through gluconeogenesis, telling you get an insulin rise, but no real glucose rise. So glucose starts to go down. So then the liver is instructed to make more glucose. But carbohydrate is almost 100%, or in this classification, it is 100% insulin driving. So that's why I tend to recommend ketogenic diets that are heavier on protein over carbohydrate. So I don't count them as equal, whereas the 1-to-1s and the 2-to-1s, they kind of treat them as equal. I also find that protein, right, we have essential amino acids and we have essential fatty acids, but there's no such thing as an essential carbohydrate. So I really do try to optimize protein in my patients when we're working on doing ketogenic diets. So how do you formulate it, or how do I formulate it? I usually try to keep carbs as low as possible, less than 20 grams per day for sure to start. I find that some people need to try to get to even 0, that they really have broken metabolism. There are others that might be able to do 35, 40, 50 and be fine. But if we start people at 50, then we don't always get to that place we need. So I can get almost everybody there if we start less than 20. And then every once in a while, I will push people down even lower temporarily until we're kind of making ketones and feeling good. And then we can play around with that. I do recommend getting or starting with at least 1 gram of fat for every gram of protein. If we are consuming up to 20 grams of carbohydrates or so, then it would be for every gram of protein plus carbohydrates. I do recommend tracking diet in a diet tracker initially, not only to ensure adequate fat grams, but also to ensure low enough carbohydrates, because I do find that people don't realize that carbohydrates come in all plant foods and some animal foods. There's a little bit in eggs, there's some in liver. If you're just eating, fleshy proteins, then we typically don't get any carbohydrates there. And I do recommend checking ketones. So if we're truly trying to heal disease, optimize our cancer outcomes, it really appears that those who had a rise in ketones had the benefits. So we really want to see if we can optimize those ketones. Do we really know what the right number is? I don't think we do. It's kind of standard that nutritional ketosis is considered a beta hydroxybutyrate or a blood level of ketones over 0.5, and that therapeutic ketosis could be as high as over 3, but we don't really know what the right thing. So I don't necessarily, if somebody doesn't make a lot of ketones, then we think of maybe trying a few other things. There are some genetic differences in folks. Maybe we need to optimize that fat, really kind of tweak things. But it's something to at least test, because I will tell you, I have many people who think they're eating a ketogenic diet and they aren't making ketones. So if you think if you're wanting to follow a ketogenic diet and you're actually wanting true metabolic benefit, then you should probably at least check in once in a while and see how you're doing. And you can do this. You can also use some of the breath meters. Urine is okay for beginners to kind of just say, are we making ketones? But it really doesn't give us a quantitative measure. So I usually recommend using blood or breath to get a better idea of where you are. And again, I don't necessarily care what type of diet folks follow, whether they want to combine plants and animals, whether they want to do it kind of more Mediterranean with mostly fatty fish, or if they want to do it pure carnivore or mostly carnivore. I do get concerned with folks that want to use a vegetarian or vegan diet because that's very hard to get enough protein and fat, because most of the vegan and vegetarian proteins are plant-based, although vegetarians obviously will include some eggs and some dairy, but it's hard to do typically without getting adequate animal proteins. Our foundational list, I think everybody's very familiar with this. So any meats, fish, shellfish, mollusks, eggs, fats. And I will say mollusks are another place where we can get carbohydrates. So oysters, and they can carry a little more in the way of carbohydrate. Fats, I usually say animal fats or fruit fats. So olive oil, coconut oil, MCT oil. I get a little cautious with avocado oils because a lot of them can be adulterated. They do carry just a slightly higher amount of omega-6s, but I do use it on occasion. So, but I really do try to stay away from vegetable or seed oils. I will say that macadamia nut oil is actually a nice option if you want some kind of a plant oil. Above ground vegetables are usually our lowest carbohydrate source, lettuces and leafy greens with very little carbohydrate. But once we start getting into the other vegetables like broccoli, cauliflower, Brussels sprouts, etc., that they are going to carry some carbohydrate. So that's why I recommend tracking at least initially. Foods that may be included, some folks will use these, others will use them a little more limitedly, but some of the low sugar fruits, high fat dairies, nuts. I find that people really can overdo nuts, and I also have seen some issues with omega-6s when people overdo nuts or joint related issues. So I usually favor the macadamia nuts, which seem to be kind of the lowest omega-6 and the lowest in the way of toxins and joint related issues, but I still will on occasion do other nuts. Alcohol, I always get questions about alcohol, sweeteners. I really encourage those to be limited, but you certainly could include them in a low carb or ketogenic style diet. I would still test to make sure that you're not responding differently to them, because everybody's a little bit different. So test your glucose, test your ketones, and listen to your body symptoms, because I told everybody this a million times, but I do have a joint in my little finger that flares when I, eat foods that don't agree with me, and stevia happens to be one of them. So just be aware. So I wanted to touch, because I always talk about insulin because I think it's such a driver, right? It stimulates that the growth pathways in our cancer cells. And when we look at fasting insulin levels and risks of developing breast cancer, we can see that the higher our fasting insulin level, the higher our risk. So these are hazards ratios, so over 9.5, and I'll tell you the average American is 9 or 10, but that's 2.5 times compared to if you only had a fasting insulin of less than 3.6. So I actually try to get people under 4 to optimize the chance of not getting a cancer. We can see the same thing in prostate, although they use different cutoffs here, but you can see having an insulin over 8.8, 2.5 times the risk compared to having an insulin less than 6.4. And if you also added in waist to height ratio, if you had both a lower insulin and a lower waist to height ratio, you had a very low risk of developing prostate cancer. Whereas if you had a high waist to height ratio and a high fasting insulin, and again, this is a completely normal and even potentially lower insulin compared to the average population, but that was 8.5 times the risk. Same with colorectal cancer, higher fasting insulin, higher risk of developing colon cancer. And when we look at outcomes, so mortality, and there's two different units on this chart. These are international, and then American units are kind of on the bottom. So those who had higher rates of recurrence had higher fasting insulins, but again, the highest group was only over 7.47, and the lowest group was less than 3.8. So, and when we look at mortality, same thing. So 8 times the mortality if we were in that slightly higher insulin group, and about 3.5 times the recurrence risk. But we know that when we follow a ketogenic diet, or really any diet, probably, to some degree, because we're cutting out usually the biggest insulin driver foods, which are always the combination of carbs and fats, like donuts and pastries and pizza, because you're getting the crust, or hamburgers with the bun. So when we combine fat with, or I should say French fries would probably be a better one, carbs with fat, we really drive that insulin response. So most diets will lower insulin, but we know from many a trial that ketogenic diets just do it far better. So this was in a group of patients who did not have cancer, following very low carb ketogenic style diets versus a low fat diet. And again, you can see all of those things that get better. And these are a lot of the things that I typically follow in my patients, which are glucose, insulin, HOMA-IR, which is an insulin resistance score, leptin, which is another hormone that is often associated with insulin resistance, but also looking at triglycerides and HDL, right? We want a high HDL. Ketogenic diets help raise HDL, as well as the triglyceride HDL ratio, which is a surrogate for HOMA-IR, or insulin resistance. This was, again, another study looking at ketogenic diet versus the American Cancer Society diet, and that was in cancer patients. Again, dramatic lowering of insulin and IGF-1, which is insulin-like growth factor 1, a sister hormone to insulin, which also drives that mTOR pathway. So I always say you should know your numbers. So if you haven't had it done, you should know what your fasting insulin is, your glucose, your HOMA-IR, your IGF-1. I also use those glucose and triglyceride to get what's called a triglyceride glucose index, triglyceride HDL, CRP, which is C-reactive protein, or an inflammatory marker, SED rate, which is another inflammatory marker, GGT, which is kind of a liver marker. It helps me actually kind of find people who maybe have a toxic burden, trying to detoxify through the liver and getting a little plugged up. And then LDH, which I don't know if I mentioned, but when we are in that Warburg kind of state, that glycolysis to lactic acid, the hormone, or the enzyme, that converts pyruvate into lactate is lactate dehydrogenase, or LDH. And when we are kind of in that broken mitochondria, higher glycolytic lactic acid cycling, LDH gets upregulated. So it's a marker that I often follow and can see pretty dramatic changes when we put people onto a ketogenic diet. So I like to use Dr. Nasha Winter's kind of test, assess, and address, but then you retest, right? So you're testing, you say, okay, these things are high. We're probably not in the most optimal metabolic state, so address it. We then say, okay, well, let's try a ketogenic diet in one form or fashion, and then let's retest. What happened to those numbers? Did they all go down? Did they not all go down? Did some of them go down? Do we need to then think, then we're retesting, we're reassessing, and then we're readdressing, and we kind of keep tweaking. And that's why I chose my tagline of data-driven health. We should always be assessing what our choices are doing to us, because we're all individuals. But I also want everyone to remember that health is more than just diet. So diet is great. It is a major driver of health. But if we're eating everything perfectly right, but we're not sleeping, we're staying up all night, we're on screens all night, we're not following a normal circadian rhythm, we don't exercise, so we're very sedentary, we can cause other issues. So we want to make sure that we're getting quality sleep, that we're following a good circadian rhythm, meaning up during the day, asleep at night, that we're exercising. And we've seen data in the past that HIIT exercise, high intensity interval training, helps to improve insulin resistance more than kind of a steady state cardio. That resistance training can significantly help us with insulin resistance as well. We want to make sure that we're maybe managing stress if we can, saying no to things if we are feeling overwhelmed, using breath work, meditation, but also getting outside, right? Vitamin D is super important, but probably there's more to being outside and being in nature than just the vitamin D. We're getting hopefully some fresh air. We're getting maybe even some forest bathing by being in natural environments with lots of trees and grasses. Also maybe doing some barefoot, or when we go to the beach or be by the water, getting some good grounding. And we should always remember to continue on community with social connections, making sure that we're laughing and we're enjoying life. If you're not ready to start a ketogenic diet, these are my usual step-by-step. So the first thing is cutting out kind of the worst foods, which would be the sugars, the grains, and the vegetable oils or the seed oils. Using maybe a little time-restricted feeding, intermittent fasting. So maybe skipping breakfast, or at least narrowing the window. I always say if we're prioritizing our animal proteins, we're making less room for the other foods. And I often find that like vegetarians or those trying to follow more plant-based diet replace animal proteins with higher carbohydrate foods. And so then we're kind of missing the point. So if we optimize or prioritize those animal proteins that have, very, very little insulin response, and especially if they're fatty, we get a nice ketogenic response. So then we have, again, less carbohydrates in the diet, and really optimizing eating real whole single ingredient foods, avoiding processing. So we don't want foods that come in a box or a bag, even if it's ground or packaged in any way. So if you read the ingredients of some sausages, of rotisserie chickens, and there's a lot of added ingredients. So really trying to stick to single ingredient foods, or even if they are already made for you, that you just know what every single ingredient is, that maybe it just has some salt and some garlic and maybe something else, but make sure that you know what all those ingredients are. I really try to keep people away from smoothies and juicing because that definitely increases their glycemic and insulin responses. And then slowly swapping out higher carbohydrate plants for lower carbohydrate plants, right? So maybe getting rid of some of the root vegetables for more of the above ground vegetables, maybe eliminating some of the legumes, and even getting maybe rid of some of the higher carbohydrate nuts for lower carbohydrate ones. But really, I encourage everybody to always just go all in. I see many of the benefits from ketogenic ways of eating are only achieved when truly in a ketogenic state. Now, I'm not saying that you have to get less than 20 grams of carbohydrate to be in a ketogenic state. Again, depending on your age, your metabolic health, your activity level, how many good mitochondria do you already have? You may be able to do things differently and utilize more of the exercise piece or the intermittent fasting piece, or other techniques to optimize your ketogenic diet. It doesn't just have to be with food. I just personally find food the easiest one for me to control. And then I just get the added benefits of when I want to throw on everything else.